Good morning. My name is AnneMarie Brescia, and thank you to Rob for that introduction. I am a pediatric rheumatologist here at Nemours, and I actually came here 20 years ago as a fellow and just refused to leave, and they gave me a little bigger office and a little lab space, so I'm still here. I'm the head of the Translational Rheumatology Research Lab, which would sound super impressive, except that it's me and one other person, my research assistant, Meg Simons. And I think we all know who does all the work. It's Meg, obviously. And so today I want to share with you just some of the more translational and clinical work that we do in our lab. And this work has been just submitted as an R01, so we'll see. But I was fortunate enough to be able to write that up because we had the MRDA award to have the time to submit that. And so that's how this all came about. And so what I study is juvenile idiopathic arthritis, or JIA. And this is the most common type of arthritis in children. And it's interesting because many people don't know that children can get arthritis, but actually under the age of 16, any child with inflammatory arthritis we call JIA, and 1 to 3 years of age is the most common age of onset. There are many different classification systems, and different subtypes have been defined. We like to reclassify every couple of years, but there's really 2 onsets based on the number of joints involved during the first 6 months of disease. And so at 6 months, if you still have only 4 or fewer joints, like the little one on the top, your top right of the screen, the patient, if they only have 4 or fewer joints by 6 months, we call them oligoarthritis. They have a very nice prognosis. We can treat them with usually mild medications, mild interventions. And then as you see on the bottom right of your screen, there's another onset, which the patients have 5 or more joints. And you can see on this patient, every small joint of the hands and the thumbs, both the MCPs, which are like your knuckles, and the PIPs, the proximal interphalangeal joints, which are the next one down on your finger, they're all swollen and involved. That's a typical polyarticular arthritis. Those patients who have 5 or more joints in the first 6 months of disease are polyarticular. They have a more difficult course, but we tend to start aggressive treatment early on. And so they tend to have fair to good outcomes, even very good with some of the newer medications. And so the reason why we want to get the arthritis under control is because this unchecked inflammation of the lining joint called the synovium leads to damage of the cartilage, which is cannot really restore itself, and even erode into the underlying bone. So the cell type that we study in our lab is called the fibroblast-like synoviocyte, or the FLS. And we kind of stole this idea from adult rheumatoid arthritis. So if you look on the picture on your left, this is a biopsy of a synovium from JIA. And the little red line it should be about 2 cell layers thick, these little synoviocytes lining the joint. In an inflamed synovial tissue, the thickness of those cells is about the black line. And so you can see they're very hypertrophied. And what's not good about these cells is they give off matrix metalloproteinases, MMPs, which degrade your extracellular matrix. They also invite T cells in. They're the great gatekeeper of the joint. And we know that these cells are pluripotent. So they are thought to be mesenchymal stem cells and can develop themselves into different types of cells down different lineages, which we'll discuss later in the chat. And you can see a picture of these cells in culture on the right. So we decided that these cells could be helpful in letting us achieve our goal. And so our goal in our lab is to predict which patients will have this tricky in-between course called an extended. So as we discussed, the initial subtype is labeled at 6 months of disease. And so before 6 months, if you still have 4 or fewer joints, you're an oligoarticular. If at, right before 6 months, you have 5 or more joints, you're a polyarticular. we treat them as such, and we do treat them with a different kind of algorithm, more aggressive in a polyarticular. So a polyarticular, you already know they're going to have this difficult course. You keep treating them aggressively. They have a polyarticular course. But if you turn to the left side of the little cartoon, before 6 months, you don't know about this group of patients who will ultimately extend, which means they play with you. They look at the beginning like they're going to fit into this subtype that has a straightforward course, a more benign course, and even years later, they recruit more joints and really take a polyarticular course. The problem with not being able to predict who will do this is that these patients have a higher risk of needing a joint replacement than the patients who start out as a poly, because you've already presumably treated them, the polys, more aggressively. So more likely to have a joint replacement. And on studies of quality of life, health-related quality of life, they have a lower health-related quality of life than patients who start out with the more aggressive course. And so we would love to be able to predict which patients would be likely to have this course before it's clinically detected by either the doctor or the patient, or any of their lab tests. So there have been attempts to predict this, oh, does this patient have a little bit higher sedimentation rate, which is a marker of inflammation? Maybe that patient will extend. Oh, does this patient have both knee involved, like a symmetric joint involvement? Maybe that patient's going to extend. But none of these clinical predictors are very reliable. And so it's really a vexing problem and very difficult for these patients as they turn into a polyarticular course. And when they do that, you're a little bit behind the 8 ball and you're kind of chasing yourself, something about the cow already being out of the barn or something like that. So we thought that since in adult RA, we know these cells are very important to the progression of disease, that perhaps these cells, the fibroblasts-like synoviocytes or the FLSs, could give us some clues early on about which patients might extend. And so this is gene expression by microarray. This is some of our early work on the fibroblast-like synoviocytes from different subtypes. So O is persistent oligoarticular. So they start in oligo. We followed them, some of these patients, for 18 years, and they never extended. ETB is extended to B. And so all these samples are patients who, from our repository, thank you to Paul Fawcett, we know that they've been followed for many, many years. Most patients who will extend in the first 2 years after onset, and these patients were all followed for at least 2 years and many for more than 10 years. These samples are the very first sample when this patient was seen, when they were still categorized as a persistent oligo, before they had extended and before they had received any steroids in their joints. E is the sample was taken when the patient had already extended, and poly is the first, but we're a poly already. And you can see with unsupervised clustering of the gene expression data, the heat map in A, where you see each column is a biologic replicate, meaning a different patient, different sample of cultured fibroblast-like synoviocytes. The gene expression for an individual sample is a column, and the row is that differential expression of that single gene across the samples. So when we compare persistent oligos to extended to B, and at which point clinically they were indistinguishable, there were 16 genes that were statistically significantly different between, in the FLS, between patients who will stay oligo and patients who are destined to extend. And you can see that except for 2 samples, they cluster very nicely, separating the oligoarticulars on the right, the extended to be on the left, and then oligo 11 and 12. We have searched up and down if there was anything different about these patients. No, they were followed for a very long time, more than 10 years each, and they never extended. So they are a little troublesome, but they clustered with the extended to be. And then we said, okay, let's compare the extended to be to patients who the sample was taken when we knew they extended and polys, and there were no statistically significant differences between those who will extend and the gene expression of the FLSs of those who are already polys and those who are already extended. There are none. So then what we said was, okay, let's see what the expression of these 16 genes that can differentiate an extended to be from an oligo, let's see what their expression is in the already extended and the polys. And you can see on the heat map on the bottom that these 16 genes, the oligos are nicely separated in their cluster on the right. Again, oligo 11 and 12 want to cluster with the extendeds and the polys, but the extended to be's, the polys, and the already extendeds all cluster together, and their gene expression is very similar for these 16 genes. So we said, okay, can we leverage these differences to help predict early on which patients will extend? And so with the help of Tim Bunnell and the bioinformatics core, we were able to pick 6 of these genes that had secreted proteins. We added 5 more genes from some protein arrays on the synovial fluid that we did, 5 more proteins, secreted proteins from the protein arrays that we did on synovial fluid. And he did a linear discriminant analysis with these 11 proteins. This is resulted in a weighted equation to be used to predict which group a patient would belong to. It turned out the weighted equation was pretty good, but actually CD14 levels alone were able to accurately classify the samples 96% of the time with a very nice p-value. Adding any other of the proteins into the weighted equation did not improve that to 100%. However, if he did a classification tree using 12 persistence and 11 extended, and they're all blinded, so a 2-step classification tree where CD14 is used first, if its level is above a certain cutoff, it would predict the patient to be extended, and it was misclassifying one patient that was truly a persistent. It was misclassified as an extended, and it could identify 11 out of 11 persistence correctly. If we added then a cutoff of IL-1 alpha level, then it could distinguish the one who was going to be a persistent, and a classification tree again of CD14 level, then followed by IL-5 level, could also, pardon me, accurately predict group in a blinded fashion 100% of the time. So this is, as we said, very important to be able to predict. So we said, okay, let's start to validate these. So we took additional samples which had not yet been used in our original studies to try to validate these. So we had an honest broker not involved in our study blind all these samples. And we've done this validation by ELISA with established ELISA cutoffs for 5 of these 11 candidate biomarkers so far. We still have to complete the bottom ones that are listed there. And some, CD14 was not as sensitive as it could have been. It was rather specific, but not as sensitive. And then IL-6 was okay-ish. It was the best balance of sensitivity and specificity. So we realized that we need more samples than what we have in our repository. We are very strict about exclusion and exclusion because there are many other confounding issues, such as, are they on immunosuppressing medication? This has to be the very first injection before any steroids were put into that joint. They cannot have other comorbid conditions such as psoriasis, thyroid disorder, syndromic arthropathy. And so even though we have a huge repository of over 600 samples, once we do all our exclusions to get a really nice, as homogeneous as we can get sample, we realized we needed outside additional samples. So what we've moved on to, and this is what is proposed in the pilot that is about to start, we are collaborating with another large children's hospital. So it's not that common to have a huge synovial fluid repository like we have that has been built for over 20 years. Many other children's hospitals just dispose of the synovial fluid or keep a very small amount for a targeted project. So Cincinnati Children's Hospital was one of the other centers that had a very well characterized synovial fluid repository, and we have established material transfer agreements and data use agreements with them, and they've done all the chart review to send us additional samples so we can validate these 11 candidate biomarkers on an outside cohort. In addition, the biobank will start collecting paired serum samples for us. Synovial fluid is great. It is a remnant tissue, but not every patient undergoes a medically indicated arthrocentesis. And so it would be nice to be able to also have a translation into a serum panel so that this could expand the applicability to patients who don't need an arthrocentesis. In addition, we will be trying to develop a multi-analyte panel, such as on the Lumina platform, hopefully for both synovial fluid and serum, just so it can be translated to the clinical space in a more facile manner. So that's where we're going with those biomarkers and where we are to try to validate those. We then have also broken out into a little bit different look at the FLSs, the fibroblast-like synoviocytes. We know they're pluripotent cells. And so we did single-cell RNA-seq of 9 samples. There's 3 biologic replicates of each of the subtypes. And you'll see on the top row, there's oligoarticular on your left, extended to be on your right, and extended to be in the middle and polyarticular on your right. And these are, again, cultured fibroblast-like synoviocytes analyzed by single-cell RNA-seq. And what we were looking for is seeing if we could identify different subpopulations within the total population of cultured FLS. This has been described by a handful of authors in adult rheumatoid arthritis, and they linked the percentages of subpopulation to aggressiveness of the rheumatoid arthritis. And no one has looked at these cells for subpopulations in JIA. And so I'm not sure if people are familiar with looking at single-cell RNA-seq, and of course I have to look at my notes. So the t-SNE plots are across the top row, and this is T-distributed stochastic neighbor embedding, and this is a machine learning algorithm to be able to see cells. They will cluster together similar to a PCA, like a principal component analysis, based on having similar expression profiles. They'll put cells close to each other. And then the row B is the UMAP. And this is just a different way of looking at the same data. It's a uniform manifold approximation and projection. And this is for dimensionality reduction. So you can see where these cells fall in space. And basically, once that dimensionality reduction is done, you can see there's a little list of cell types next to each of these UMAP plots. Using standard reference data sets, this program used human primary cell atlas data. They tell you what type of cell your population is identifying as. So you can see chondrocyte-like, fibroblast-like cells there. And so what's important about this is that when we look at those subpopulations, we saw a dramatic shift in the percentages of the FLS subpopulations between the different subtypes. So what you're seeing on the left-hand side of your screen on the little bar graph is that colored blue is the FLSs from oligoarticular, persistent oligo, orange is the extended to be, and gray is the poly. So if we, and you can see the p-values of these comparisons on the little table on the right-hand side of your screen. So we see that there is a significant difference in the percentage of smooth muscle cells between if you're going to be a persistent oligo or if you're a chondrocyte-like cell. I mean, I'm sorry, a polyarticular. There's a significant difference between that percentage of the cells that are smooth muscle cell-like. If you move over to the fibroblast-like, there is a significant difference between extended to B, having a much higher percentage of fibroblast-like cells when compared to oligoarticular. Now, it looks funny that it's not statistically significantly different from the polys. That p-value was 0.07. I think that is likely due to the high error bar, the wide error bar on the polys, and also on the extended to B. When we look at the chondrocyte-like cells, we see a dramatic increase in the percentage of chondrocyte-like cells among the subpopulations of the polyarticular, and you can see these significant p-values on the bottom right of your table that chondrocyte-like is statistically significantly different between polys and both oligos and the extended to B. And so we had already identified in previous work that I haven't shown you that surprisingly FLSs from JIA they have a chondrocyte-like phenotype, whereas control FLSs do not. And what I mean is that the JIA FLSs had high amounts of collagen 2, collagen 10, aggrecan, and COMP, which is a marker of cartilage turnover. And so it's very interesting that as the patients have a polyarticular course, we're seeing that the FLS are more chondrocyte-like. Also interesting about this to us is that part of the morbidity of JIA is bony overgrowth and leg length discrepancies. And so a lot of the other more basic stuff that I'm not showing today is that we're working on BMP4 and TGF superfamily signaling within the FLSs to see if this is contributing to possible endochondral bone formation leading to the bony overgrowth and leg length discrepancies. And so the next step for this FLS subpopulation is to try to leverage these shifts in the FLS subpopulation percentages to predict the course in JIA. So just as we were going with biomarkers in the first part of our work, we're trying to see if we can get at this prediction from another angle. And so luckily through the MRDA, I was connected with Rich West of the UD Flow Cytometry Core, and he has been absolutely wonderful in helping us work out a protocol to try to immunophenotype these subpopulations using flow. And then we'll test the robustness of these percentages of subpopulations to try to predict the subtype, to see if this can be another way to get at prediction of the subtype. And I wanted to, well, thank you all for listening. I'm afraid I may have gone a little over. And of course, as I said, Meg Simons does all the work. And then my K mentors, which Rob appropriately said is wrapping up in like 2 days, were Kate Sullivan, Chief of Immunology at CHOP, and Carlos Rosé from rheumatology here. And then lots of other people have helped, especially you can see lots of nice people who've generously donated money. And then, of course, thank you to the Delaware MRDA, which is wrapping up, and the pilot project, which is starting very soon. And so I am going to mute myself and would be happy to take any questions.